Good day, everyone. Welcome to this morning's discussion regarding the entire spectrum of glaucoma therapy. This is a very broad topic, so we'll have a lot to cover and a lot to get through. I'm Lou Cantor, Professor Emeritus at Indiana University. For those of you who don't know where Indiana or Indianapolis is, we're about 3 hours south of Chicago, Illinois. So we're going to evaluate and talk about how we approach glaucoma therapy. Any one of these subtopics, just medical therapy, laser, incisional, could probably fill the entire hour. So as again, we're going to try to put some perspectives on things, hit some highlights, and talk about how we maybe approach glaucoma patients with our different therapeutic approaches, and also based upon what's available in your particular area or region. Here's my disclosures to start with, none of which I believe are especially relevant to the discussion. So let's talk about glaucoma just very briefly for some background. So glaucoma is a group of diseases that share this common pathway of optic nerve damage and associated visual field loss, for which elevated pressure is just a risk factor. We know there are other factors that are going on behind the scenes that are independent of pressure, but currently elevated intraocular pressure is the only therapeutic approach we have to modify the course of the disease. We know that about 4% of persons, depending upon the studies, that have pressures over 21 develop new glaucoma damage, that a lot of ocular hypertensives per year develop glaucoma. But we also know that about 1/3 of glaucoma patients do not have consistently elevated pressure above 21. So we have to be on the lookout for those patients, as we can be fooled. Even patients with high pressures, 1/3 of the time their pressures may be normal, depending upon when you check them. How is the pressure generated? Again, just some very brief background here. What happens and how is the intraocular pressure modulated? And this ties into our therapeutic approaches. Aqueous production is one end of the equation, the amount of fluid being put into the eye. This is produced in the ciliary body, as shown in the image here, in what's called the non-pigmented ciliary epithelium. There's several methods that do this, secretion being the primary process for producing aqueous inside the eye. Aqueous production happens at a certain rate, about 2 to 3 microliters per minute. Therefore, given the average eye, the entire aqueous in the anterior chamber will turn over in about 100 minutes, since the volume of the eye is 2 to 3 milliliters. It varies during the day and night. Those patterns are complex in some patients, but it does go down at night. The reason that's important is, do we want to give an aqueous suppressant at night as a medication when normally the aqueous production goes down by nearly 50% at night anyway? And overall, the amount of aqueous being produced decreases with age as well. So aqueous suppressants may be less effective when the aqueous production is less. Aqueous outflow, we have the two sides of the equation and it's primarily the trabecular outflow that determines the intraocular pressure. It's a pressure dependent. We'll look at the medications and how they affect the trabecular outflow. And we'll also look at the medications that affect the unconventional, or what's called uveoscleral outflow, which accounts for a smaller percentage of the total outflow in the eye, though that varies between patients. It's independent of pressure. That process continues regardless of what the pressure is. Trabecular outflow increases as the pressure increases. This is a look at our meshwork and the complex channels that fluid has to go through and between before reaching the canal and ultimately exiting the eye in this complex connection with the episcleral venous system and all that is involved with aqueous outflow. There's a lot of areas for resistance, but the primary areas again are at the trabecular meshwork, where and then the canal, which can actually collapse I'll show a picture of that. And then the episcleral venous pressure, that pressure around the eye and the vascular system, also provides a somewhat lower limit to how low pressure can go without some sort of surgical intervention. And this is again, the uveoscleral outflow is a bit more nebulous system as it goes through the ciliary muscle, through the tissue, back into the suprachoroidal space, and ultimately out of the eye, and accounts for, again, a smaller percentage. So all of this combined leads to the intraocular pressure and what it exists in the eye. In majority of glaucoma patients, the problem is at the trabecular meshwork in the canal. That's where the majority of resistance is. Um, uh, there isn't glaucoma where you make too much aqueous, for example. It's really an outflow problem. Therefore, a lot of our therapies are directed at that. When we start thinking about treating glaucoma, it's important to think about what's our goal. Um, what kind of glaucoma are we dealing with? There are various standards recommended through the American Academy of Ophthalmology, preferred practice patterns, and others globally, the American Glaucoma Society, the European Glaucoma Society, and so forth. But in general, if you have just an ocular hypertensive, we're usually not too aggressive with treatment. As a matter of fact, we may just observe. If we decide to treat, probably just want to get the pressure into the low 20s. If it's above that, 20 or 25% below whatever their baseline pressure was, that would be a not unusual goal. Most of these patients, quite honestly, I will watch and observe unless they have a lot of risk factors that suggest to me that they're at high risk of developing glaucoma. In a patient with mild glaucoma damage, which is defined as optic nerve damage, but no visible or discernible visual field loss, getting the pressure under 21 with a 30% reduction below baseline is usually considered a reasonable target. For moderate and severe glaucoma, we get progressively more aggressive. And I think it's important here to also bring up the point that in glaucoma, we have a real tendency to overtreat glaucoma suspects and ocular hypertensives, but to undertreat real glaucoma with damage. We need to be aggressive and probably more aggressive than we are many times in our patients with moderate to severe disease. Now, there's some things that may modify what we might think of for the target pressure. If a patient's had a history of a disc hemorrhage, as shown in the image here, they have a thinner central cornea, so we may be fooled by the pressure a bit. If they've developed rapid progression or have severe glaucoma in the fellow eye, they have a strong family history of blindness due to glaucoma, they're younger, we may want to set our targets even lower. And maybe that pressure, that patient with mild or moderate disease, we want to treat them as if they have advanced disease and be more aggressive because of factors like this. Sometimes we can be a little looser with our standards as well. If a patient has short life expectancy, very poor medical history and status, if their disease is shown to be very slowly progressive or stable, and if they have a thick central cornea, um, those may be reasons to be a little bit less aggressive with the target for what we want to achieve with the pressure lowering. So how do we lower pressure? How do we start to address it? I'm going to start with the medical treatment approach, and we'll run through the classes of medicines. There's obviously going to, on a global level, there's going to be a lot of variability in what's available, if any medicines are available or certain medicines. But I'll give a broad overview that's certainly representative of what we have here in the U.S. And in many parts of the world, but not everywhere. Most commonly, and our most common class of medications that are used today, especially as initial therapy, are the prostaglandins. We'll talk about those. We have adrenergic agents that we use in glaucoma, and they're sort of contradictory. We use beta blockers, particularly non-selective beta blockers such as timolol that we'll talk about. And we also have adrenergic agonists, or things that stimulate adrenergic pathways. So we have blockers and agonists that are both effective, but in different ways. And primarily in that class is our alpha-2 selective. Carbonic anhydrase inhibitors, we mostly use the topical agents that we'll talk about. Parasympathomimetic or miotic agents, the direct acting, such as pilocarpine, is a representative of this class. And we have others. We have the newest class, the rho kinase class of drugs. Then we have combination agents, and I won't say much about hyperosmotic agents, but they are available for short-term emergency treatment or pre-surgical. So while this is the standard accepted sort of paradigm for how to treat glaucoma, um, this is under a lot of discussion, though. Uh, Traditionally, it's medical therapy, trying to stick with as few medicines as possible, starting with a prostaglandin. As we'll talk later, laser has moved up in this paradigm and is being considered more and more as an initial therapy for some patients, or at least earlier in the course of therapy, not after you're on already maximum controlled medical therapy. Surgery, however, for the most part, is still not your first choice, though it may be very effective. And we'll talk about surgery, but it's where surgery is applied and balancing that with the potential risks of surgery versus the long-term benefits. So we'll talk about this whole scheme as we go forward. So back to medical therapy. As I mentioned, our beta adrenergic antagonists, the beta blockers, there's a variety of those that are non-selective. The number one and the oldest in the group is timolol. We also have a beta 1 selective betaxolol, which is a little bit safer for patients who have certain pulmonary predispositions to asthma, but not as widely used. In our adrenergic class, we're not using the non-selective agents as much currently, but primarily the alpha-2 agent, which is represented by brimonidine most commonly. Carbonic anhydrase inhibitors, we do have the oral agents as listed here, but generally, most commonly, we're using the topical forms, which took many decades to develop, dorzolamide and brinzolamide. Prostaglandins, as again, usually our first line therapy for when we're starting medical therapy. Latanoprost was the first innovator in this class now nearly 30 years ago, and has changed how we treat glaucoma. Our newest is the rho kinase class, which is represented by natarsadil. And then again, the parasympathomimetics represented by pilocarpine primarily, though there are indirect anticholinesterase drugs available that can be useful in certain circumstances. We have a lot of fixed combinations. In the US, we have timolol combined with a carbonic anhydrase inhibitor or brimonidine as an option, brimonidine and brinzolamide, so an adrenergic agonist with a carbonic anhydrase inhibitor, latanoprost with natarsadil, the rho kinase, and prostaglandin. And there's others throughout the world. There's no way to, there's triple combinations in some parts of the world, though not in the US. I've even seen some patients bring me bottles that have a quadruple combination. I worry about when you start putting too many medications into one bottle. These medications don't always mix together well, and I think it would be very difficult to get the full effect if you're combining too many medications together. And that's even an issue with some of our just fixed combinations of two medicines. There's evidence that one of our older fixed combinations, timolol and dorzolamide, um, used as a fixed combination isn't quite as effective as using timolol and dorzolamide separately. So there's always some compromises with these medications. And then, as I mentioned, the hyperosmotic agents can be used when available for short-term or urgent use. I always like to tie our medications back to the mechanism of action of how these drugs work. Cholinergic agents affect trabecular outflow. Carbonic anhydrase inhibitors reduce aqueous production. Beta blockers reduce aqueous production. Prostaglandins increase uveoscleral outflow. and or trabecular outflow to varying amounts. The rho kinase is a trabecular outflow drug, but also decreases episcleral venous pressure, our only class of drugs to date that does that. And then our selective alpha 2 agonists like brimonidine increase uvoscleral outflow and decrease aqueous formation. So if you begin to think about mechanism, you begin to think, well, how do I want to use these drugs? How do I want to combine them? I think it makes most sense, and I try to many times when I'm starting therapy, and particularly when I'm advancing therapy, to think about combining different mechanisms. For example, I'll try not to add an outflow drug if I'm already on an outflow drug. I'll try to combine an outflow drug with an inflow drug. I think that in general, many times will give a better result, depending upon again what's available in your area. But it's just one way to think about our medications, not just haphazardly and randomly by chance, but to think about the mechanism and to apply that to how we might treat a patient to get the best pressure lowering effect. The other thing about medications that I want to, and I'm not going to go through these slides in great detail. Lee Alward did a magnificent review of the side effects many years ago. But all of our drugs have side effects. So we have to keep in mind not only the pressure lowering effects, but what are we subjecting the patient to? With timolol, the primary ones are cardiovascular, slowing the heart rate, lowering the blood pressure, and pulmonary, bronchospasm, asthma. But there are others as well. And if you ask patients, these are much more, some of these other side effects that I won't read through all of them are much more common than you might initially assume because we don't ask about them. And patients don't voluntarily, um, uh, you know, relate these symptoms sometimes. With brimonidine or alpha 2 agonists, um, uh, decrease in blood pressure, dry mouth, dry nose, drowsiness, and fatigue are very common. With the topical carbonic anhydrase inhibitors, we get a fair amount of red eye and we can get a contact dermatitis, what's actually a hypersensitivity reaction. Systemically, metallic taste is a very common thing that I hear, even with the drug, especially with the drops. But systemically, I hear some patients talk about paresthesia and GI upset, even with the drops, not just the oral medicines. The issues of aplastic anemia and Stevens-Johnson's, these more severe systemic reactions, remain questionably associated, um, but we have to be used carefully and thought of if a patient begins to develop symptoms of any of these severe reactions. The prostaglandins, most of the symptoms are local and ocular with redness of the eye. You get what's called this periorbitopathy, where you get a sunken orbit look some ptosis and some periocular darkening of the skin, iris pigmentation. It can be seen as well, particularly in those patients who have light tan iris to start with. Patients with a very blue iris or very dark iris typically don't show this. Systemically, it has been associated with some systemic inflammatory symptoms, though these are relatively infrequent. And our old friend, pilocarpine has a long list of potential side effects as well, especially if a patient overuses it. But the most common ocular ones being the pupillary constriction, causing trouble with vision, some pain around the eye from ciliary spasm, uh, redness of the eye, stinging, conjunctivitis, and so forth. So just a reminder that these drugs do have side effects. And our rho kinase class seems to be very safe systemically, but does cause some unique ocular side effects. The hyperemia is not uncommon, but subconjunctival hemorrhage is a side effect we don't typically see. Corneal verticillata, where you get deposition in a whorl-like pattern on the cornea, can occur as well. How do we minimize side effects from our medications? Uh, This picture shows two things. I love this picture um, because when I show it to people, they say, well, she's doing nasal lacrimal duct occlusion, and that's preventing uh, much of the eye drop from going down the tear ducts and into the back of her throat and being absorbed systemically, and increases the amount of time the drug stays on the eye and penetrates better. The only problem is that's not what she's doing. She's trying to do that, but if you look where she's really just pinching the side of her nose. I've tried to teach patients to do good nasal lacrimal occlusion, and to really do it, you got to push way back and deep into the inner canthal area and with a lot of pressure. So most patients do what she's doing. They just push on the side of their nose. But what she is doing that is as effective as nasal lacrimal duct occlusion is she's closing her eyes. Simple eyelid closure decreases by 50% the amount of the drug that gets into your system, number one. And number two, it allows for the drug to stay on the eye longer and get better absorbed. So just simple eyelid closure. I stopped trying to train patients and teach them how to do nasal lacrimal occlusion because nobody can do it right consistently, but everybody can close their eyes. So we talked about establishing this target, this goal, which is where we want the pressure to be, where glaucoma damage is no longer likely to progress and is halted. Now let's move on to laser and speak to it for a few minutes. So there's been a lot of changes in how we apply laser, and I'm going to stick to open angle glaucoma. There just isn't time to go through all the angle closure laser surgical options and studies right now. So we're going to stick to open angle glaucoma. Uh, the primary laser that was first introduced for this now 40 years ago was argon laser trabeculoplasty, where a small 50 micron spot of argon laser in the range of about 7 to, I rarely went over 1,000, but you could go up to 1,200 milliwatts depending upon the pigmentation in the eye. Um, I would usually do 100 spots over 360 degrees and do an entire treatment. I did not like dividing the treatment because I just wanted to get it done. And you're supposed to treat the very anterior half of the pigmented meshwork. So you sort of half in the pigmented and non-pigmented meshwork, and you get a little bubble formation. That would sort of be our endpoint because the laser energy would be absorbed, cause a tissue reaction that I'll show you in a minute. And that would ultimately lead to the effect that we would see about a month later as it has time to take effect. This is what the gonioscopic picture of the laser spot looks like. That's not great focus, but oftentimes it's hard to get that really well focused and to get it right in the right spot on the meshwork. More recently, we've had the SLT laser. It's called a Q-switch laser. It's actually a 532 laser that is then frequency doubled to give it 1064 nanometer wavelength, which is infrared. It's got a very short nanosecond pulse. It's got a 400 micron spot. And again, I usually apply 100 spots over 360 when I do this treatment. This is comparison of the size of the ALT, the argon laser trabeculoplasty spot with the white dots versus the SLT, which is 400 microns. Um, Most people are a bit astonished when they think of this. With the ALT, placement of the spot was very important and is very important if you're using that laser, because if you don't get it in the right place, it won't do anything. With the SLT laser, the spot is so big, it's almost impossible to miss the meshwork. And you're just trying to get laser energy in there, and it works by a different mechanism. So the SLT laser is more forgiving and allows you to have greater assurance that if you're looking at the meshwork and you got your spot reasonably well centered, you're going to hit the meshwork. You just can't miss it. This is what the ALT laser does on scanning electron microscopy. It creates a thermal burn, as shown in figure A there. There's a higher magnification view of some other parts of it, but look at figure A there on your left. That's what the argon laser trabeculoplasty does. It creates this coagulant burn versus SLT, which does essentially nothing to the architecture of the meshwork, but the laser energy is absorbed within the trabecular meshwork cells, and it initiates a sort of a biologic cytokine response that brings in various factors to help clear up the meshwork and open it up without the thermal energy burn of the meshwork. So for this reason, one of the primary advantages of SLT is that you can repeat it. Um, SLT and ALT work the same as an initial treatment. There, there's no studies that show any different effect as primary laser treatment. However, SLT is a bit more effective and safer for repeat treatment. And we'll talk about that a little bit more in a second. Um, Here's one of the early studies looking at SLT laser, and this is looking at SLT laser as well as patients who had who had a prior ALT laser and got an SLT as a secondary procedure, and you see it works the same. So it works very well as a repeat laser for most patients. Most recently, just in the last couple of years, we've had the LIGHT trial, which looks at primary SLT versus eye drops for the treatment of glaucoma. This was a large study, over 700 eyes, standard randomization, moderate to severe glaucoma, some ocular hypertensives who were elected for treatment as well, and the pressure ranges are given. The majority of the patients throughout the study had just one laser. Medication burden was reduced. Um, they got good pressure lowering, and disease progression seemed to be improved or better or lower in the SLT group. Um, and it seemed that the patients who started with eye drops were more likely to need surgery. And this is looking at repeat laser from that study. The red line um, represents repeat compared to, so you can get good success. What this shows is as the SLT laser, primary laser, begins to stop working, which they can do over time, over a year or two, the average is about 50% um, of the time the pressure is creeping back up after 2 years. You can repeat the laser and regain a good response for repeat laser. So the take-home points from that study were that patients may be offered laser trabeculoplasty as a primary therapy, and this represents a big change. Still today, though, the majority of patients will opt for, and certainly the patients I treat seem to opt for at least trying a drop or two first, but laser is certainly reasonable to consider earlier or as primary. Patients with severe disease did worse regardless of medicine or laser. You can repeat it. It seemed to be pretty cost effective compared to drops, again, depending upon what the situation is with the availability and cost and generics for medications in your region. Also said, it's typical after these, and just side note, that, to check these patients after a month. That may not be necessary, but I still do that. Now, what about beyond laser? Let's talk about surgery, incisional surgery. Um, uh, the biggest change in glaucoma has occurred here with the evolution and introduction over the past decade or so of the microinvasive glaucoma surgical approaches, the MIGS procedures. So what is a MIGS procedure? These microinvasive glaucoma surgeries. They're designed to be clear corneal with minimal tissue manipulation, safe, rapid visual recovery, and of course, the lower pressure and be efficacious. Um, uh, there's a whole classification of the use of these different devices now. Steve Vold did a nice summary a few years ago, and this just keeps getting more and more layers added to it. Um, but it certainly has increased in use MIGS, especially in earlier stages of glaucoma, before going to our more invasive procedures of tube shunts and trabeculectomies that we'll discuss in a minute. So again, going back to our mechanism, the problem in glaucoma is that the meshwork and the canal stop functioning. And therefore, the resistance to outflow goes up and up. And so most of the procedures today are focused on the canal of phlegm and the trabecular meshwork. This is a procedure that is not a MIGS procedure, but I think it's very instructive into what's trying to be accomplished here. This was a procedure called canaloplasty. It's still done. I haven't done one recently because of the MIGS procedures, but I used to do this procedure very commonly. This is an external approach, conjunctival incision. You create, and these are some intraoperative photos I took, a deep sclerectomy. So this is a non-penetrating approach where there's a superficial flap and you remove a deep scleral flap and amputate it, and you unroof Schlemm's canal. There's still the inner wall of the canal there and decimes. And then you put a catheter in it. You can thread that catheter around for 360 degrees. And then retrieve it as it comes out the other end and tie a suture to it. In this case, it's a 9-O-proline. And then you back that catheter back all the way around 360 degrees in the eye while injecting viscoelastic and dragging the suture behind it. Once you have the tube out, you cut the suture from the tube and then tie it. And now this is a gonioscopic picture that shows the suture in place that's in the canal um, with some tension on it after viscodilating the canal and doing this deep sclerectomy and going for 360. And these are some pictures, ultrasound photographs that show what that looks like. On your left is a preoperative photo of typically what the outflow system in a glaucomatous eye looks like. You don't see the canal. The meshwork isn't visible on an ultrasound, but the canal is completely collapsed. On the right is what happens after canaloplasty. And the arrow, it's hard to see, but the arrow is actually pointing to the suture. There's a little white dot there at the end of the arrow, and that's actually the suture. And you see how it's pulling the canal open. And by viscodilating the canal, you also create micro ruptures so that fluid can get into the canal. So that's essentially, in many ways, what we're trying to accomplish with these MIGS procedures is to get fluid through the trabecular meshwork and into the canal and keep the canal dilated and open and functioning so that fluid can then go downstream where it's supposed to go. So these are some of the goals of the treatment. Quality of life is a big thing with the MIGS procedures, and patients have high expectations. We have a lot of different MIGS options, and I'd like to break them up into what I consider mini MIGS, which are just affect a small area of the meshwork and canal. And I put phaco, just straight cataract surgery in this, because cataract surgery is a pretty decent glaucoma surgery in many patients. Uh, but the phacoemulsification combined with the iStent, with a hydrus, with a Cahook dual blade KDB trabectome, these affect a small area, usually under 3 clock hours of the meshwork is bypassed by these stents. Then we have more max MIGs, which involve 180 to 360 degrees of the canal. Then we have less invasive glaucoma surgeries. These are bleb forming procedures with tube shunts. We'll look at these. The Zen is what we have available. There's also the PreserFlow in other areas of the world. Then there's other procedures, and there's been a lot of interest in the suprachoroidal space, but currently there's no devices for that available in the US. Then finally, trabs and tube shunts. One of the important things, which I always like to emphasize when it comes to these MIGS procedures, is patient selection. There's a lot we could talk about here, but I think the most important thing is, would you want to do a MIGS procedure in someone who has advanced field loss, such as on the right, that is beginning to threaten fixation? or is the patient on the left a more likely candidate and a more favorable candidate? And while there are reports of using MIGS procedures successfully in patients with advanced disease, I'm not fully on board with that yet. So I prefer to keep the MIGS procedures for the more mild to moderate disease um, for most patients. There's exceptions to everything, but think about stage of disease when you're choosing how to proceed. Here is a list of the various canal-based procedures from iStent to Hydrus to the GAP procedure, the KDB blade. We have a variety of these, and these all increase trabecular outflow by bypassing the trabecular meshwork in some way and getting fluid into the canal. And there's a lot of options. It depends on what's available in your area. Um, um, a simple goniotomy with just taking a needle, what's called a bang procedure, bent ob internal needle goniotomy. So you can take a 25 gauge needle and just bend the tip of it and use that as a goniotomy blade. It works very well and costs nearly nothing. These are standard needles. So you can do this um, with devices, or you can get creative on your own as well. As I said, the suprachoroidal procedures, none are presently marketed in the US. The CyPass was withdrawn due to concerns about the corneal endothelial cell layer and loss of endothelial cells. There's a iStent Super in clinical trials. Um, there's these translimbal devices, the Zen being the one that we have available in the US, which is a translimbal tube um, to bypass the meshwork to do basically a safer, less invasive trabeculectomy. Um, it doesn't always work as well as a trabeculectomy, certainly, but it is a less involved approach, and for some patients may be a reasonable approach. And this is kind of what they look like. They're fairly small, and the PreserFlow is there by that penny down there on your left, and that's the Zen implant on the right. These are fairly small devices, and are seem to be tolerated very well. But this was a study done several years ago now, but I've always liked the way that they present it, and I don't think anything has substantially fundamentally changed since they did this study out of Italy, looking at a systematic review and meta-analysis of studies looking at MIGS procedures, and they had a set of criteria. They had reasonable criteria to include, like reasonable follow-up, you know, and usual sorts of quality standards. They looked at all the procedures that they could. They ended up looking at over 3,000 studies. And what's critical here is that they identified over 3,000 studies that related to the procedures that they had available, and found only 33 of them that met the criteria to be included in their analysis. 1% essentially. Um, uh, so it does limit the data, and that's still true today. The majority of studies on these are non-randomized case series, case reports, and things that don't provide us generalizable information that we can really apply to patients. So they had only 33 decent quality studies to look at. And these are those studies, and you know, the individual studies aren't important here. What's important is to look at that line down the middle. And the dot with the bar, that's the mean with the standard deviation of the amount of pressure reduction obtained versus the control um, uh, in those studies. And if you're to the left, that means you lowered pressure -2, -4 millimeters compared to control. On the right means that the MIGS procedure actually did worse, that the pressure was higher. Um, and if you look at this and just look up and down the graph, you see that in general, the MIGS procedures are effective, have some wide range of variability depending upon the device, but the pressure lowering on average is fairly modest, maybe around 4 millimeters or so, um, or less. So these are often not the paradigm shift for a patient procedure. They may get them off a medicine or two. They may lower their pressure a little bit. But if you really need uh, a lot of pressure lowering, there are other procedures to consider. And here that brings us to our standard and what I consider our gold standard procedures of trabeculectomy, this guarded partial thickness filtering procedure we'll talk about, and tube shunt. Trabeculectomy indications, it's generally when the pressure can't be maintained by non-surgical therapies, and you need to move ahead because there's damage. You've either exceeded maximum tolerable medical therapy, you've tried laser, and the optic nerve is still failing or likely to fail, and vision loss is progressing. Those are standard indications for trabeculectomy. The technique, trabeculectomy is a bit of an art. There's a lot of different ways to do it. It's not as standardized with a device, and some of the mixed procedures. What's nice about them is they are very standardized. You go in, you do this, you put this device. It's not as surgeon dependent. Trabeculectomy is still very surgeon dependent. How you do the conjunctival flap, how you apply antifibrotic agent, how you make it. I'll run through the steps here pretty quickly just to give you some of my thoughts. Um, One of the first debates you hear is, should you do a limbus or fornix-based conjunctival flap? Well, here's the pros and cons. I do a limbus-based conjunctival flap with a fornix incision. I get the best results. I've done these procedures now for over 40 years, but occasionally I will do a fornix-based flap with a limbal incision because of certain things about that patient. I can do both, but I get better results myself because of how I do it. But you can't isolate any one step in the surgical success. It depends on a lot of other parts. This whole thing has to work together like a symphony. It's not if one step's going to make or break the procedure. Um, Most of the time we're going to use mitomycin. There was, several years ago they did a hand raise. How many people are using, mitomycin in their glaucoma surgery? This is at the American Glaucoma Society meeting, I think, and like 100% of people raise their hands. But the problem is we're using them all very differently. The concentration, the time, how we apply it. Do we inject it? Do we use a sponge? Most of the time, people are soaking a sponge a little or cutting off a piece of a wax cell and sticking it under the conj. The problem is sponges are not designed as drug delivery devices. They're designed to do the opposite. They're designed to absorb stuff, not release it. So I think we get a lot of variability in how people may press on the drug or how much they saturate it and how much actually gets to the tissue. It's not as controlled as we would like it, but it is effective. It is effective, but in a lot of different ways that individual surgeons have taken advantage of to try to improve their outcomes, and they get good results. The scleral flap that you make for trabeculectomy, what does matter is the relationship of the flap to the underlying sclerostomy, the hole, and that it be about half to two-thirds scleral thickness. You don't want it too thin or too thick. What doesn't matter is the size or shape of the flap, whether it's triangular or rectangular, trapezoidal, 3 millimeters, 4 millimeters, 2 millimeters. What matters is, will it leak at the end? And so you can do a lot of different flap shapes, sizes, as long as it's the relationship to the sclerotomy and it allows it to leak. You can create the underlying sclerotomy with a punch or a blade. There's certain ways to do that. There's an express shunt, which I haven't used for some time, but did use, which kind of standardizes this approach. But there's a lot of different ways to create the hole so that this can leak and form the fistula that we want. I still like to do an iridectomy. Some people have moved away from iridectomy. I find if I don't do an iridectomy, there's a higher risk of the iris getting into the sclerotomy. But you do have to be careful when you do an iridectomy not to get into the ciliary processes or the zonules or the anterior hyaloid. And how you close the scleral flap differs among surgeons. I usually just put in two sutures and leave them fairly loose. Some people put in multiple sutures and they want it pretty tight at the end because they plan on releasing sutures or cutting sutures or doing suture lysis. And then the conjunctival closure. A lot of people do this differently. You close it separately or in a tenons and cons separately or in a single layer. There's lots of different ways to close a fornix-based incision with a limbal incision. This is a limbus. This is one of my cases where I'm closing the conjunctiva and tenons in a two-layered fashion. I close the tenons first, then go back and close the conj, and I'm as far back in the fornix as I can be. If you're doing a limbal incision, you can do a wing sutures, just one on each end, and pull the flap down, or there's a Condon-Wise approach where you run a mattress suture along the limbus as well to close that kind of incision. Lots of different ways to do it. What you want to achieve is something that's watertight. I find that in general, if you have a limbal incision, it's more likely to leak, and it's harder to get it watertight, but you certainly can. And then post-op, um, my mantra is always that the success of surgery for trabeculectomy, um, 50% of it is what happens in the operating room. The other 50% is what happens post-operatively and how we manage that patient and constant monitoring and follow-up, releasing sutures, how you taper the steroids, doing massage, all sorts of things to try to assess and the outcome or to improve the outcome of the surgery. Um, Suture lysis is something that can be performed to release sutures in a planned or unplanned fashion. You may plan on doing it. I usually don't plan on lysing sutures. I put in two sutures and leave them fairly loose. But if it's not leaking as much as I want and the bleb's not as high as I want, I'll use a laser and cut one or both of my sutures. These are bleb forming procedures. We created a bleb appearance grading scale many years ago to look at the height, extent, vascularity, and so forth of blebs. So you do have to be comfortable dealing with blebs and monitoring them and scheduling patients for follow-up as appropriate, depend on their other bleb. There's a lot of different things that can happen with complications from glaucoma surgery that we need to be aware of. As I said, with postoperative care, there's a lot of different options to look at. If the pressure is low, with a low bleb, you may have leakage, choroidal effusion, or overfiltration. If you have a low bleb but high pressure, you may be looking at aqueous misdirection or pupillary block. If you have a high bleb but low pressure, you may be looking at overfiltration or high bleb with high pressure, you may be looking at a suprachoroidal hemorrhage. You need to be able to work through these options and know how to recognize the complications of surgery and manage them. Certainly, infection is a concern over time. Usually, infections start with a bleb leak and then progress to infection because the bleb leak was allowed to persist for some time or maybe wasn't identified. Lots of risk factors for infection, mostly antimetabolites and avascular blebs. Finally, with the tube shunts, there's a lot of different reasons for tube shunts. Even primary tube shunts have been looked at as a primary surgery, but usually it's after other things have failed. We have non-valved tube shunts, the Maltino and Barvelt. We have valved, primarily represented by the Ahmed today, that restrict some of the outflow. These devices do vary in size, and it does appear from studies that have been done that the maximum amount of effect you can get from a single quadrant device is probably around 250 square millimeters. So when I use, for example, the Barvelt, I'll use the 250 over the 350, except for on individual cases. Trabeculectomy and tube shunt in general, trabeculectomy works better than tube shunts in many studies, but there are higher complication rates with trabeculectomy reported, particularly wound leaks and bleb associated problems such as dysesthesia, where a patient feels the bleb, but encapsulated blebs and other things also occur. There was a study, another study looking at uh, trabeculectomy versus tube shunt after 5 years of follow-up. Very similar pressure reduction. If you look at the larger graph, just more meds were required in the tube shunt group. There's the primary tube versus trabeculectomy. So the previous study was done after trabeculectomy had failed. This is looking at primary tube versus trabeculectomy. Large numbers of eyes, randomized, and the primary TVT study showed similar results. You get the early hypertensive phase. That's why the tube shunt has that pressure spike sort of here. That's the hypertensive phase. Long term, the results are similar. A little bit better with the trabeculectomy, more meds in the tube shunt group. Similar results here. Trabeculectomy survival curve was better. So the take-home points is that tube shunt surgeries as primary before trabeculectomy have a greater risk of failure, higher pressures, higher rate of reoperation, more need for medicines, but they do have a lower postoperative complication rate. And tube shunts perform poorly if the starting pressure is low. So I think trabeculectomy still remains the gold standard for glaucoma surgery. Um, it's been shown to decrease the rates of localized and global visual field loss as well. And I'll end with this slide. This is this is a slide I've used for years, and you can put medications, in your head on the graph where the ALT, SLT lines are. And it sort of shows you where everything starts to line up in terms of how these different procedures work and how they're reported over time. Phaco can work, laser trabeculoplasty can work, and that's with about a 20% decrease in pressure, 25%, medicines 25 to 30%. Then you get the various eye stent, canaloplasty, but up at the top remains trabeculectomy and tube shunts as our most effective surgical approaches for glaucoma. So with that, I will uh, end my formal presentation, and we'll turn to the Q&A. So how the first question here in the queue is how does the efficacy of non-selective, I assume beta blocker, differ from selective beta blockers? And uh, they're similarly effective. The non-selective tends to be in studies head-to-head between timolol and betaxolol. The non-selective probably works a little better. Um, and is a little bit more effective. The only time that I really use betaxolol or non-selective beta blocker is in patients with a known history of pulmonary disease. What are some cases where we cannot combine outflow pathway with inflow pathway drugs? Um, there really aren't any unless patients have intolerance to the drug. Um, so that's always a limiting factor, either because of ocular or systemic side effects. Um, you can really always look to do that, and you just have to see what patients tolerate. Is the outcome of MIGS procedures hampered if performed after a repeated SLT? Great question. In the Black population, can TRAVS be combined with MIGS procedures in advanced disease? Um, to answer the first part of that question, it's been unclear what the effect of SLT has on MIGS, but it's thought to be minimal effect if at all. So many patients that have MIGS procedures have had previous laser. Uh, in the Black population specifically, I don't know that we have studies that will address that for us. So I can't really answer that. Um, I really wouldn't see a circumstance where you combine a MIGS and a TRAB unless you're doing a trabeculectomy after a MIGS procedure has proven to be not sufficient. So there's lots of patients who have had, say, a phaco with a MIGS procedure performed, and their disease is uncontrolled. A couple years later, you've already done maybe 360 degrees of MIGS procedure, and then your next step is a trab or a tube shunt, depending upon your preference. I think we've talked about some of the surgical interventions. Again, the main scenario seems to me that selects patients is how advanced is the disease. Uh, Earlier disease, you can get by with this with the more limited MIGS, what I call the mini MIGS. More moderate disease, I go to the more 360 MIGS. And if their disease is more advanced than that, then I'm probably looking at a more invasive procedure such as a trabeculectomy. If I understand the question, in terms of diagnosing glaucoma, I I never try to rely on one thing. Um, Pressure, optic nerve, visual field, that classic triad. I think you have to look at everything and it has to all fit together and make sense. Um, there are times when the field looks worse, but the patient's pressure is fine and the OCT looks stable. You're not going to necessarily make a change unless you see all those factors starting to line up. So I would. It's not a question of which is better. It's a question of the all of the diagnostic testing and glaucoma should work together. Um, there's there's different lenses for for the use of ALT. Generally, I use a three mirror gonio lens, or there's specific lenses. There's a Latino lens. It's the little thumbnail looking rounded one. That it just depends on which lens, which type of contact lens you have available to you, as long as you can get a good view of the meshwork. Um, but most standard multi-mirror, whether it's a three or four mirror lens, will have different lenses for looking at different angles into the eye, and you want the mirror that gives you the best view of the meshwork. How many times can SLT be repeated? Great question. I have one patient where I've done it 8 times, and it still works. It's not working as well now as it used to, perhaps. Um, but this is a patient who's very resistant to any surgery. He had surgery in the other eye elsewhere some time ago, and it didn't go so great. So he's really big on laser, and it keeps working. So the answer is you can keep repeating it as long as it's still working. But there probably is a limit, and I think that patient is an exception. You just have to evaluate the treatment and versus the options, see how it worked last time. Um, in general, the laser is never going to work better when you repeat it than it did the time before. Yeah, so if it didn't work great and wore off in 3 months, um, there's probably little reason to repeat it because you're not going to do any better. So that's my rule of thumb, that if they got a good response the last time and it lasted a while, probably at least a year, and their pressure's creeping back up, then I'm inclined to at least offer it as an option to repeat it. Um, if it didn't work well, I'm not expecting anything more than that if I were to repeat it. Um, There's an there's an ophthalmology resident here. Glaucoma medications can cause a wide range of effects. How do you usually manage switching from one medication? What are your main considerations when deciding to make a substitution? Great question. So, um, when adding medications, you have to think about what the medicine you're on is doing first. All of our drugs have a certain failure rate. For example, a beta blocker, 25% of the time, if a patient's been on timolol or a similar beta blocker for 2 years, it's going to be ineffective. They will have tachyphylaxis to the drug and it's not working. Um, so your ideal thing is to recognize that and not to add another drug to a drug that's not working, but to stop the first drug. Now, sometimes it's hard to tell. So if a patient's pressure is creeping up, and I don't know if it's their glaucoma getting worse or the drug just getting less effective, I'll sometimes just stop the drug briefly, have them back in a month, and see what the pressure did. If it didn't change, then that tells me that drug wasn't working. So then it's important to stop that drug and start something else. If the pressure goes up, then you know the drug was effective. It just now the just the pressure's gotten higher. So then you have to add something to it or advance the treatment or do something else. So I think that's the main caveat is we tend to add too many drugs on top of drugs that just aren't working. And we need to be vigilant and take the extra steps to sort of weed that out. Um, if a patient achieved the target but is experiencing significant side effects, what do you do? Well, um, if if you're asking patients to continue doing something that's causing bad side effects, you're ultimately going to fail. Whether it's tolerability issues or systemic issues, doesn't matter. Um, our point with treatment is to maintain quality of life. And if you're causing someone severe side effects, that's impaired. So I I think it's ultimately a losing battle if you're trying to work around side effects and ask a patient to continue to do that. It's not a reasonable thing to do. I wouldn't do it. I wouldn't want to be on something long term that's causing me side effects. So their compliance is gonna go down. So you should stop what's causing side effects and advance therapy. Our goal is to prevent blindness and maintain quality of life. And sometimes that just involves changing course. Um, uh, so the priority is to preserve quality of life and prevent blindness. So switch course if you have to. Don't ask patients to do things that you wouldn't do yourself long term. Um, retinal attachment. Is there any treatment in future? Yeah, I'm not sure I quite follow the whole question, but retinal detachment, obviously, if there's been a MAC off, or the macula off RD or chronic RD, visual prognosis is very poor. The key to retinal detachments, and I'm not a retina specialist, is to diagnose them early, get them fixed, hopefully before the detachment has progressed through the macula, where there's then going to likely be long-term compromised vision. Um, what is my opinion on trabeculectomy performed with an amniotic membrane graft, and what are the advantages? Yeah, this is a good question. Some of my associates have done this. I haven't done the amniotic membrane for trabeculectomy. I've used it a few times to help repair blebs, leaks, and things where we needed some tissue. Um, so I think the jury is out on what it does, and if it can augment trabeculectomy, I would look forward to those studies. I just don't know that we have evidence to date that amniotic membrane improves the outcomes, but it's an interesting question for sure. Um, my my regimen for topical steroids post trabeculectomy, um, uh, it's important uh, to look at the eye and not have a rote say, you're going to do it 4 times a day for 3 weeks or 4 weeks, then you're going to do it less frequently. Sorry. Um, and so forth. I think what you really have to do is look at the eye. So I will usually start on, I typically use 4 times a day steroid unless the patient has a particular inflammatory component or looks very inflamed. Then sometimes we'll bump it up to 6 times a day. I'll generally maintain that regimen for at least 3 to 4 weeks and then start a slow taper. But I'm looking at the eye. If the eye looks particularly inflamed or the conjunctiva looks particularly inflamed, then I will slow down my taper. If the eye looks really quiet or there's hypotony, I'll back off the steroid a little quicker sometimes. So it depends on what the eye looks like and how inflamed the eye looks. But in general, 4 times a day for 3 to 4 weeks, then a gradual taper to where we're off the steroid probably by 2 months. Um, the recovery period from MIGS is much quicker than trabeculectomy or tube stent, no question. A phaco MIGS procedure can look every bit just like a cataract surgery on day one. They can have 20/20, 20/25 vision and a quiet eye, and you can't tell they had a MIGS procedure done just by looking at them from across the room. That's not the case for a trabeculectomy or tube shunt. You can tell when those patients have had that surgery. So MIGS are much quicker visual recovery, and that's one of the good selling points of a MIGS procedure, is that fast visual recovery. Um, but the trabeculectomy and the tube shunt, you're looking for more of the long-term control of glaucoma in patients who need it. Can ALT be performed after inefficient repeated SLT? Um, uh, Good question, but I've not seen data looking at ALT after failed SLT, but I wouldn't have any reason to expect that it would work. Um, so I don't know of a study to reference on that, but uh, some patients just don't respond to laser for whatever reason, and you just have to move on to something else, whether it's ALT or SLT. So if you've tried SLT and it didn't work, I don't see a reason to go to ALT. And likewise, if you performed ALT and it didn't work, there's no reason to go to SLT because as a primary treatment, they work the same. There's no difference in the studies. Um, are prostaglandin analogs contraindicated after cataract surgery in uveitis patients? Does it increase inflammation? There's always that risk. So I consider it. So when we talk about cataract surgery and uveitis, most of the times you can get by with a prostaglandin if you need it, but it's one more risk factor. It's like for cataract surgery, what are the risk factors for getting post-operative cystoid macular edema? Well, it's diabetes, it's maybe they've got some vascular disease, and now a prostaglandin. It's one more risk factor for that patient to get macular edema. Likewise, in the uveitis patient, it's one more factor that could increase the inflammation. Not that it does all the time, but it could. Um, and then next question here is, do I have experience with MLT? Um, I don't actually. I've read the articles on it. Again, if you look through the history of laser, there's been lasers used in glaucoma for decades and decades, even before ALT. People were firing different things into the eye, and they all worked about the same. So I think anything that gets laser energy into the meshwork can stimulate it. And I think it's more of a biologic response that happens, whether there's thermal damage or not. You get this biologic response with cytokines and upregulation of metalloproteinases and recruitment of macrophages that cleans out the meshwork and sort of rejuvenates it a bit. Um, but uh, but I don't have direct experience uh, with the MLT. What are the major complications of trabeculectomy? I think I went through the major list, and the most worrisome of those is, of course, bleb-associated infections, because that can cause you to go blind. You can also get, suprachoroidal hemorrhages and other things that can be very devastating, you know, post-operatively. But in the long term, bleb-associated infections are the thing that we need to monitor. We need to look at blebs more. We need to Seidel test them with fluorescein to see if they're leaking more than we do. We need to take care of blepharitis and infections around the eyelids more than we do in patients who have a bleb, because that's often the source of where the bacteria come from that cause the infection. So we have to be treating dry eye. We got to be treating blepharitis. We got to be monitoring the blebs to prevent it. Why do we have to wait for the vision to fail before doing trabeculectomy? We don't. As a matter of fact, we shouldn't. We should be doing surgery and doing whatever intervention it takes to prevent vision loss And I think that relates back to my point that if in real glaucoma, moderately to severe glaucoma that's progressing, we need to advance therapy and get to whatever it's going to take to stop it. So we shouldn't wait. We should be doing some of these things earlier and not waiting, and really hone in on what is it going to take in that patient to preserve their vision and their quality of life. So I would not wait. Um, Oftentimes, unfortunately, patients present when they're pretty far advanced. Um, and in those patients, I think we have to be aggressive. There was a question about how do you decide on which stent to use? Um, Interesting and great question. We get asked that sort of thing. There's so many options right now. The That's why I sort of had those categories. So there's the mini MIGs, like I listed, and it's whatever one you get comfortable with. They all seem to work fairly much the same in terms of the outcomes. So I think you need to get yourself familiar with one of them and get good at it. If it's a more the maxi MIG where you're going 360, there's several devices and approaches to doing that. They all work probably about the same. You need to get good at doing one of those because there's some little nuances to the technique for each one. So I think it's choosing within that class what's available in your area, what makes sense, and then getting good at it yourself. Um, how much IOP reduction by ALT, SLT? It's generally around 25%. Um, there's a range, of course, to the effectiveness. You're not going to typically get the 35, 40% reduction in pressure you can get, say, with a prostaglandin analog, um, though you may in some patients. The average is around that 20 to 25% pressure reduction, which is about similar to a beta blocker in terms of medications. What are my thoughts about combining different MIGs with phaco? Um, Many of the MIGS procedures are approved, at least in the US, only to be used in combination with phaco because that's how the studies were performed. They were add-ons to phaco because they are more effective in that situation, and that's how they were studied. Because phaco, lowers the pressure to start with, so you add something to it, it makes sense to maybe get patients off meds. Um, uh, so, but there are also some of the MIGS procedures, the more canaloplasty goniotomy devices that are approved for standalone use as well. But the majority are not only effective when combined with cataract surgery in the US at least, their approval is to be used in combination, not as a standalone procedure. Um, From those three options of management, which one is the most commonly used? Um, I think still the most commonly used approach to dealing with glaucoma is still medications. I think the majority of it, I think, every market study shows globally that medication use far, far outweighs laser or surgical options. But I think we're also slowly seeing a migration of laser and surgery higher up in the hierarchy, and that we're moving more towards other interventions after maybe a couple meds have failed instead of going to three or four, which gets very complicated for patients. So, but I think still today, medications clearly are the most commonly used approach for glaucoma and will remain so for a while. But that doesn't necessarily mean forever. Um, what is the best treatment for pseudoexfoliation glaucoma? Trab first or tube directly? Well, or other secondary glaucomas. Uh, pseudoexfoliation, just to stick to that, because secondary glaucomas is a broad topic, but just with pseudoexfoliation, um, I think you treat it just like primary open-angle glaucoma, but more so. Pseudoexfoliation tends to respond less well to medicines and even laser, and so you do end up in surgery earlier, and it can be more aggressive and just doesn't respond well. But I think the steps are the same. you start with medicines or laser, and then you advance and try to control it. And most patients with pseudoexfoliation can be controlled. Um, uh, Similar, can be controlled without having to go to surgery. Um, uh, but if you have to go to surgery and medicines and laser haven't controlled it, um, my usual first choice would be a trabeculectomy before a tube shunt. Others would differ, but that's what I would do. What is the best option in advanced glaucoma? IOP control with drops, but worsening visual field. While we use the pressure to gauge our treatment and set our goals, if the glaucoma is getting worse, it doesn't matter what the pressure is, it needs to be lower. So if the visual field is truly worsening and and the pressure is 10, that means something, that the disease is progressing. So you have to treat the disease, which means you have to advance the therapy. Now with drops, a pressure of 10 that you're obtaining in the office, and you know, most of the time what that means is that the pressure is 10 for 3 seconds when the patient comes in to be checked every 3 or 4 months or 6 months or whatever it is. So that doesn't mean the pressure is 10 all the time. So a pressure of 10 on drops can be highly variable. A pressure of 10 on no medicines after a trabeculectomy is essentially a flat line. That pressure doesn't vary. So the assumption is that if someone's getting worse with a pressure of 10, probably the pressure isn't always 10. There's some variability going on, either just from peak trough effects of the medicines, compliance, whatever it is. But you need to advance. You're not treating the pressure, you're treating the disease. The pressure is only a surrogate for what's going on with the disease. And the disease is nerve damage and field loss. And if they're getting worse, you need to be doing more. Um, is the outcome of MIGS affected by the level of pigment in the trabecular meshwork? Uh, uh, there's some thought that areas within the meshwork, often the pigmentation is not regular. There's sort of hyperpigmented and hypopigmented areas within the TM. And it's thought actually that the collector channels and things may be more associated with the pigmented areas. And therefore, if you place your stents, if you're doing those near that it may work better. But in general, you're bypassing the trabecular meshwork when you do these procedures. So I think the level of pigmentation is of less importance than it might seem, and there aren't studies that really show that it matters. Um, can you perform SLT in neovascular glaucoma control with anti-VEGF and laser with persistent ocular hypertension? You could try it. My guess is that the results are probably not going to be or be good. When you have neovascular glaucoma, what causes the pressure elevation is that a fibrovascular membrane grows over the trabecular meshwork, and even if you treat them and it regresses, there's still this fibrous membrane that's blocking the meshwork itself, and that's what's causing the elevated pressure. Um, so I would not be optimistic about uh, SLT laser in a neovascular eye, even when it's been successfully treated, because the mechanism for their pressure elevation is different. It's not what goes on in primary open-angle glaucoma. When do you remove releasable sutures or do suture lysis? It depends on how you do the surgery. So some people do their trabeculectomies and they want to do everything to avoid hypotony and low pressure early on. So they will tie the sutures tight, planning that at 1 week I'm going to release these two sutures, and at 4 weeks I'm going to release these two, or whatever. They have a plan, and then they modify that plan depending upon what the patient looks like. Um, um, Other times, such as in my case, on the opposite end of the spectrum, I like to leave the eye fairly leaky at the end. I leave the anterior chamber really filled with viscoelastic at the end of surgery, and I count on that to hold the chamber for a while until the eye starts to heal. And I never plan on suture lysis unless the pressure starts to creep up or they're not draining as much as I would like. And then I would release a suture. But for me, that's probably, I'll do suture lysis one in every 15 to 20 trabeculectomies. 5% of the time, maybe I'm doing suture lysis. And I've used releasable sutures in the past. The primary situation where I've used releasable sutures is in patients who I consider to be at very high risk, particularly of a suprachoroidal hemorrhage, where they've had a hemorrhage in the other eye, maybe they're aphakic or real high myope, and I want to be able to control it without doing suture lysis. The problem with suture lysis with a laser also is that if you have some subconjunctival hemorrhage, you can't see the suture to lyse it. So there may be circumstances where if you have a little bleeding under the conj postoperatively and you want to release the suture, you can't because you can't see it. With a releasable, at least if it's exposed on the cornea, you can always release it whenever you want. So in some of these really high risk eyes, I have done releasable sutures where I put a suture through the sides of the flap and loop it out underneath the limbus and tie it on the cornea. And then at whatever point I want, I can just cut that suture and pull it out. Um, but those are a relatively small number of cases. Um, do you perform trabeculectomy with mitomycin or without? When you use my, I do mitomycin in every case. What I do is um, vary the concentration a bit. In higher risk eyes, I use zero point 0.4 milligrams per cc concentration of mitomycin. So someone who's failed a previous surgery, maybe has some conjunctival scarring, an African American patient who I see, someone who's at higher risk for failure, I'll use zero point 0.4 of mitomycin. For the standard trabeculectomy, in someone who I don't consider has a lot of risk factors for failure, I'll use zero point 0.2 milligrams per cc, and I'll generally use it for 2 minutes. And all patients then rinse the eye off very thoroughly afterwards. So, but I use mitomycin 100% of the time currently. Um, do you think 180 degrees KDB performed through two opposite incisions may obtain big? I mean, if you can get to 180 degrees, I think that's hard even through two incisions. If you're good enough with intraoperative gonioscopy and your technique to get more of the angle than 3 clock hours, and you can think you can get up to 5 or 6, yeah, it might improve the outcome. I don't know the studies that have compared the degree or how much of the angle was treated with KDB and the outcomes, but it would make sense that the more you can do, the likely more effect you might get. Trabeculoplasty recovery period. After laser trabeculoplasty, I assume this means when do you know what you got? Um, Generally, you don't know the pressure response right away. It takes at least a month, maybe 6 weeks. So I still always see these patients back 4 to 6 weeks after the laser and then assess what the outcome is. And in the meantime, I try not to change anything else. I don't change their medicines, keep everything else the same so I can isolate what's been the effect of the laser. How about patients with pre-existing corneal dystrophies? Yeah, a lot of the topical glaucoma medications can exacerbate, um, uh, particularly dry eye. When you're talking about the corneal dystrophies, such as endothelial dystrophies, then you have to worry about the carbonic anhydrase inhibitors, which can inhibit carbonic anhydrase activity in the corneal endothelium. And if you have a marginal cornea that's on the edge of developing frank edema or corneal edema, you may tip them over with a CAI. So you do have to be a little bit careful with those medicines. Um, Preservatives are another issue in patients with corneal disease. A lot of patients the benzalkonium chloride, the BAK, and the in the formulation can be rough on cornea if there's already pre-existing corneal problems. So you may need to consider non-preserved options for the medications if available. Um, Getting towards the end of the questions, but also the end of our time. I've seen a small serous pigment epithelial detachment post SLT in a patient, which resolves spontaneously in 2 to 3 months. Is this common? No, it's not common. Um, I don't know how that could have been associated with the laser. Anything's possible, I suppose, but I suspect it may have been just a coincidence. I do not use steroid drops post SLT of any sort, pre or post. I did with ALT, but SLT really depends on that biologic response, and you don't want to suppress that. It's more theoretical than evidence to show this in my in full disclosure. Um, but um, uh, so I don't use any steroid or non-steroidal drops or anything pre or post SLT laser. I just do the laser. Is there a role for OCT angiography in the diagnosis of glaucoma earlier? Yeah, great question. Great area of research to look at what's going on from a vascular standpoint. At current, our current understanding of OCT angiography and what's going on around the optic nerve in glaucoma is incomplete and how well this may be or how helpful it may be. But at some point, I wouldn't be surprised if we do more vascular analysis in patients with glaucoma to give us some clue as to what's going on with their disease, because I think there are some vascular, at least vascular autoregulatory abnormalities. Can I please re-enumerate again on rho kinase? Uh, the main things I said about rho kinase inhibitors is that they improve trabecular outflow and they also do lower episcleral venous pressure, it assumes. The only class of drug that does that. Very safe drug systemically from an ocular standpoint. You get subconjunctival hemorrhages, these little small ones, which are not unusual. Sometimes they're bigger. Um, you get corneal deposition of the drug in this whorl-like pattern that forms corneal verticillata. But a very effective drug and a new class of drugs for us to have another tool. Causes a lot of red eye, and a lot of patients don't tolerate it, but it can still be very useful. A bleb infection after trabeculectomy. Um, it depends on the status of the infection, and I break it down into three categories: bleb infections. Number one is an infection that's isolated to the bleb. So it's just a blebitis, if you will. There's no anterior chamber inflammation, no hyphema, no anything else. So that's stage one. Stage two is when you're now getting some spillover inflammation into the anterior chamber with some flare and cell, maybe even a little hypopion. And then grade three is full-blown endophthalmitis with vitreous involvement. Um, the last one is easy. They go to my retina colleagues and they get full bore tap and inject for an antibiotics, vitrectomy if needed, and so forth. They get the full retinal treatment for endophthalmitis. The grade one, where there's just some isolated, infection of the bleb, I will treat aggressively with topical antibiotics and fortified antibiotics, often on an hourly or every other hour basis, but just treat topically. Maybe add an oral fluoroquinolone, which I would use moxifloxacin or one of the fluoroquinolones. Um, it's stage two is where it gets a little tougher, where there's some spillover inflammation. I will often treat them um, with aggressive topical again, just like a bleb infection. I will definitely add um, oral antibiotics. You can get pretty good penetration with oral antibiotics in those eyes. as well, and that will often be sufficient. But I will follow those patients every day. And if they show any signs that they're progressing to an endophthalmitis, I will get them to my retina colleagues and let them take over from there. Um, oh, on the chart, what is ELT? That's excimer laser trabeculoplasty. Sorry, I didn't have time to go through all that. So that's an approach that was Mike Berlin and others have worked on, where with an excimer laser you can actually ablate, just like with an excimer, a small area of the trabecular meshwork and create an opening so that fluid can go through. And I think that's our last question. Um, So with that, I want to thank everyone for their attendance, for the great questions. Hopefully this was useful, and I look forward to seeing you on a future CyberSite adventure and discussion. Thank you very much.